Right. So now let me get this shared. If you're joining us, please go ahead and say hi in the comments. Let us know where you're joining us from. And I will have us go in here in just a minute. Okay. I think we are live streaming in all the places. Okay. So welcome everyone to this month's TBI Talk with Dr. Perry Maynard from Integrated Brain Centers in Denver, Colorado. And today we're going to be talking about visual problems after a brain injury, how they can kind of present or manifest, and what can be done about them. I think visual problems are probably one of the biggest things I hear people talk about. I know for me, I knew something was wrong with my eyes, but I couldn't quite articulate it, right? Like I just told the eye doctor, like my eyes don't feel like they're working together. And acuity wise, my eyes were working fine. There was no damage. Like I didn't have a retinal tear or anything like that going on. But I just knew something wasn't right. And I told my neurologist, I think my dizziness is coming from my eyes. And she kind of blew that off like, oh no, that's not a thing. And so I struggled for almost 3 years before I found functional neurology. So I'm always excited to talk about this topic. So where would you like to start, Dr. Maynard?
I think your kind of comment is a good place because so many people go to the optometrist, and this is nothing against optometry, and we're not talking about neurooptometry, but just general optometry. Most of my patients, same thing. They go and they get a clean bill of health, and so think about when a lot of people go to the eye doctor, like you said, it's like, well, the anatomy of my eye is just fine. So we know that. Of course, depending on what happens with a head injury, whether it's a traumatic blow to the head or the eye, right, there can sometimes be trauma to the actual eye itself, right? Whether it be the retina, the nerve, the actual eye itself. But so often that is totally fine in individuals, right? It usually comes down to some other things of one, how well are the mechanics of the eye working? And that's the other piece too, is that sometimes if it's not massively huge, that then sometimes doctors are like, well, it doesn't quite look normal, but it doesn't look pathological, right? And that's the other big thing, right? We've talked about in past things is concussions and milder traumatic brain injuries sometimes are more functional injuries, right? Where it's not always clear, like a stroke, where I have lost function in this hand, I can see it on imaging. It's more of a functional thing. So when we're looking at vision and we're understanding vision after a brain injury, we have to look at it more functionally. Of course, we want to know, like, does their retina work and can they see? Because if that's not working, then we need to address that.
Absolutely.
But a lot of times it's an issue in the areas of the brain that control the eyes, or an issue in how the brain is perceiving vision, which we'll chat about. So a lot of times like central versus peripheral vision, or how well is the eye playing with other sensory systems. At the end of the day, our brains are these big gelatinous things that they care so much about sensory processing. They care so much about vision, about gravity from my inner ear, my neck to tell me where my head is, hearing to tell me where things are relative in case I need to run away from something that is a threat. So our brains love sensory information, and brain injuries just destroy sensory processing. So it's very common for the eyes to maybe not start playing well with other sensory systems. Most commonly, what we see is that we know our eyes and our inner ear and our cervical spine or our neck, along with hearing, are literally intimately intertwined within our brain. And this makes sense. If I am in a threatful situation and I hear something, I need to look and I need to orient my head towards that threat, and then I need to make a response. So it makes pretty good sense that they'd all be wired together. So we need to have ways of understanding, and we'll chat about this in a little bit, are these visual symptoms that we are feeling because the eyes aren't playing well with another system? And I think that's really important to tell. And I think that's where, when people ask, like, what's the difference between, let's say, neurooptometry and functional neurology, at least I can speak for functional neurology. I think where we really do a good job is looking at how our systems playing together. I think where neurooptometry shines and does really well is, how can I change your visual perception? How can I create better integration between central and peripheral vision? If your eyes are deviated weird, how can I create them to be on more of a level playing field? And that's why I think the two professions marry so well together and can work so well.
Yeah.
So I think another good place is, what are the symptoms that people feel? Very commonly, what I see is that individuals tend to be very light sensitive. They tend to be very overwhelmed by busy visual environments, right? So maybe it's going to a grocery store, maybe it's being a passenger in a car, going to a concert, right? They're not sure what's really going on, but a lot of visual stimulus or a lot of motion can be provocative. Someone might have double vision, triple vision. I've seen quadruple vision, right?
Wow.
Which you could imagine would be very disorienting. And we can chat about some of the reasons for that, right? So where people are seeing multiple things, they have trouble with busy visual environments. Computers and readings are huge things that individuals suffer with after brain injuries, right? So I find computer screens to be one of the biggest pains in the butt of trying to get, especially with the advent of like the Zoom boom and COVID. It's like everyone's now on computers, and everyone's like, hey, I'm doing great in everyday life besides when I'm on a computer for 12 hours, right? And we can chat about the reasons behind that as well. But that's very commonly the symptoms that you see, but it could be for very different reasons that hopefully we'll be able to get into and chat about.
Yeah. So maybe let's talk about some of the different ways it can present itself. Like maybe you do or don't realize it's your eyes, right? Like you were saying, like if someone has double vision, like you obviously know that's probably something up with your eyes. Then there's that like sense of like motion, like you constantly just feel like you're moving or the world's moving around you. That was kind of what I had going on. I lost some of them. I had them and now I lost them. But just the different ways that visual stuff can present.
Yeah, no. So I think the way I think about it, we'll break it down, is one of the first things is, do your eyes move efficiently in the environment? So when we're thinking about vision, like I said, we want to think, do you have the mechanics for your eyes to work together? And how is perception? So when we're thinking about the eyes, one of the first things I'm always saying is, are the eyes on level playing ground? So very commonly with brain injuries, you might see that the eyes aren't playing on a level ground, right? And so if we think about deviations, we can have vertical deviations and we can have horizontal deviations. So ultimately, if we think about my eyes, right, they're like a camera. And I would ideally, if I'm using two cameras or binocular vision, I would like them to work together. So first thing I'm always saying is, are they starting on an even playing ground? And what you see a lot of times with brain injuries, they are not. One eye might be turned in, one eye might be turned out, one eye might be high, one might be low. That can be because of, damage to a muscle, yes, but sometimes it can be due to the brain ignoring an eye or suppressing an eye and saying, I'm just not going to listen to that. I don't like what that's saying. or it can also be because of inner ear issues. So one's perception of gravity is off, so their vision skews. Because the way I look at vision, and this might be different than how the optometry world looks at it, but I think of vision as it gives me my world reference frame. So my inner ear tells me where I am in the world, right? It gives me longitude and latitude. It says, here's where I am in the United States. And then now that I know where I'm at on that grid, my vision can tell me the world relative to me, right? So they work very tightly together so that if I have a malperception of where I am in the world, I might have my eyes do things off of that malperception. So going back to it is saying, are the eyes on even playing ground? And then the next thing is really three things. Can I keep my eyes still? Can I move them quickly from target to target or to different points of interest? And can I track and understand motion? It's really simple to think about. And so I'm saying, can an individual keep their eyes still? What you see a lot of time after brain injuries is people's eyes get shaky or they get tremoring.
Yeah.
So no different than like a tremor.
And a lot of people will explain that they feel like their eyes are shaking. Mm-hmm.
Yep, exactly. And so when you look at that, depending on how bad it is or how big it is, will manifest in the symptoms. So sometimes more than like a 5-degree difference, you'll get double vision. Less than that, you'll get blurred vision. And then this might be sometimes people will be like, I don't know, like my visual world is just foggy, or I feel really dizzy with motion. And so we're always saying, like, can they keep their eyes still? And so we do test to look at like, how well can they hold them neutral in different planes? But then when they're tracking, how well can they keep them stable? This is what we call gaze fixation or gaze stability. So that's one thing that can get disrupted in a brain injury and cause visual symptoms. The next is my ability to track motion. What I mean by that is that I always tell patients, you have an internal gyroscope, that's your inner ear, and you have a visual gyroscope, which is a system called your optokinetic system. So when I'm moving throughout the world, my internal gyroscope needs to be telling me how I'm moving, but I need to have a visual reflex that matches me moving. Because if we think about it, if I spin to the right, it looks like the world goes to the left, right? And ideally, if those signals match, I know that I turn to the right. This is a big predicament with people with brain injuries. And so we need to look at, one, do they even have the neural circuitry to make these reflexes happen? And this is where we look at things like pursuits. So looking at a thumb or a target, follow it left to right, up and down, diagonals. And we want to see, one, like, can they just do it in unison, like eyes work together? Is it stable, or are they getting these tremors or shakes during it, which can happen? Are they too slow? So when they're trying to track a target, they get these jerky motions, right? So they don't predict speed very well. So that's another thing we want to look at, like, how well do they do with motion? And then, of course, everyone's favorite is the optokinetic strips, right? So where we have a bunch of busy patterns fly by you. So no different than watching a train go by. This is what's called an optokinetic response. And this looks at how well can you process visual motion. And so this is really important because some individuals might have a brain injury where they no longer have an optokinetic reflex, and that's why they hate motion, because they can't perceive it. And you have a lot of people where the reflex works just fine. It's the way the brain perceives it. And it's really important we differentiate the two, because in one, you need to find a way to give them that reflex back. In another, you need to find a way to get them to better tolerate that response. So right off the bat, we're saying, do they have the substrate to make the eyes move appropriately? And then the next piece is saying, how well are they perceiving that input, and are they interacting it with their inner ear? So going back to motion sensitivity, right? Motion sensitivity is very common post-head injury, right? Riding in cars, riding in boats, like people just feel very ill with motion, right? Sometimes you give them those stripes in the clinic and they feel like they're spinning. And so if we think about it, like when I'm sitting in a car and all of a sudden the car starts moving next to me, right? All of us have had this. All of a sudden you feel like you're moving backwards and slam your foot on the brake. So if we think about that, if the world is moving and that reflex works, my brain should say, okay, something just moved in the environment, inner ear, what did we just do? And ideally, if the inner ear is healthy, it should say, we did nothing. And then my body says, I don't think we're moving in the car. And if that works really well, then we know that car is moving relative to us. But with brain injuries, the parts of the brain that merge all of these systems together can sometimes be disrupted. And so when they perceive visual motion, they have trouble comparing it, right? We know that in acute inner ear infections, our brain will sensory reweight. So let's say we damage our inner ear, and all of a sudden our brain's like, I don't really like what that's telling me. And so what it will literally do is it will reweight centrally, and it will say, hey, this person's not no different than like a business. Think of an organization. Think of you have a team, and you're like, so-and-so is not holding up their end. We need someone else to pick up the slack. Ultimately, the same job has to get done. We have to have the same outcome, whether it's 5 people doing it or it's 2 people doing it. And the brain works similar, and will say, hey, let's turn up the dial on vision and let's become more visually dominant, right? The problem with this is it leads to visual sensitivity, because if I'm now very reliant on vision, how am I supposed to know world motion versus self motion? So we really have to identify in brain injuries, how have they sensory reweighted? How have they recompensated? Are they listening too much to their neck, and that's why their neck is tight, giving them headaches? Are they listening too much to vision, and that's why they're motion sensitive? Because then at that point, sometimes rehab is focused on trying to get them to listen to their other systems. So like their inner ear. So maybe we're doing a ton with vestibular stimulation, but then we want to merge them together, right? It's like, it's no different than, like I said, going back to the team analogy, maybe so-and-so is not doing great. So you sit with them and you say, hey, let's figure this out, right? Let's figure out like what we can do to help you be successful in this organization. Now let's reintegrate you back with the team, right? So that you all 5 can work as a cohesive group for, the better of the organization and have good outcomes. And so that's where the rehab might be very different for someone who's sensory reweighted versus someone who just has a broken optokinetic reflex versus someone who's got damage to their eye, right? And so this is why everything in our exam is to figure out what's going on with the eye. Do they move appropriately? Do they even work together? Am I paying attention to both eyes? So suppression. So there's a concept of suppression where I ignore input from an eye, which is very common. And so sometimes we have to do exercises to get rid of suppression. So I start using my eyes together. And then we have to say, are they playing nice with the other systems? And that's really kind of how we look at visual complaints. And that's kind of the spectrum of where, once again, you can have someone with motion sensitivity, but it could be for 2 vastly different reasons. And what you do could be for 2 totally different reasons. And this is why we see it. This is why patients go to neurooptometry and like, that did amazing. And then another person, they're like, I don't know. Same thing with functional neurology.
Right.
Someone goes to functional neurology, like, that didn't help me. Neurooptometry helped me, or vice versa. And what we try to do, and what I try to do with a lot of the neurooptometrists in Denver, I think this is why we're all so successful, is we've learned what each of us are good at. So we know when to refer to each other.
Yeah.
My goal is to figure out when I need to refer to neurooptometry. And I know neurooptometrists will know, like, hey, there's some like weird where like things aren't playing well together. Can you take a look at this? And I think that really helps get patients to the right place versus like all of my patients where I've done vision therapy, I've done prisms, I've done chiropractic, I've done PT, I've done massage. And like it kind of has worked, but not really worked, or I've done functional neurology, so really trying to understand the whole picture.
Mm-hmm. Yeah. And, so for someone who's watching, who's, maybe a year or more out, and they've been struggling with these different things, and, like with me, right? The optometrist didn't know how to help me. The neurologist didn't know how to help me. The doctor didn't know how to help me. So there's still hope for you, right? Like I was 3 years out before I found functional neurology. And I mean, we cleared up that dizziness stuff so quickly. I was like amazed. I still had a lot of other stuff going on, but that dizziness, we got that under control. And that like when you're scrolling, you talk about computer screens, and for me it was scrolling. Anytime I scrolled or on my phone, that scrolling motion would make me like, whoa. And every once in a while it'll still get me. But I now know what to do, right? I have my exercises. But so what is your message to the people listening who are like, okay, that describes something going on with me?
Yeah, I would agree with you. There's tons of hope, and I have patients all the time who feel they have done everything, but when you're in this world long enough, you've realized is you've only scratched the surface, because unfortunately, like you've realized, traditional healthcare is just not well, I don't even want to say educated. I mean, I don't think they are. They're just not given the tools to be successful in this arena.
Right.
They're just not taught it. And unfortunately, like you said, far too often do you have neurologists or different people who are like, those things have nothing to do with it. And it's, they couldn't be farther from the truth. So if you've gone down the conventional route, when we say conventional, let's say your PCP, a traditional neurologist, optometrist, even ophthalmology. I have seen plenty of patients go to ophthalmologists who are very smart, brilliant people and very good at what they do. But once again, I don't know if they are well equipped in this arena, because a lot of times it's just not bad enough. It's kind of like going to a neurosurgeon and being like, oh, I got this like little thing going on. They're like, come to me when you have like something serious. You know what I mean? So it's just, it's a wrong tool for the job. It's like, that's the best way I think to think of it, is that they're totally capable. It's not their jam, right? They're really good at what they do. But in this world, you need individuals who look at functionality. So like I said, I don't want to speak for neurooptometrists too much, because I am not one, but my understanding and how I view it is that optometrists can do, or neurooptometrists can do what optometrists can do, but they look at the functionality of how is the brain perceiving vision. They are looking at how you're perceiving different colors. They're looking at peripheral central vision, right? They are looking at functionality versus just pure anatomy of the eye, right? And so anytime you're doing something with a brain injury, you need an individual who looks at functionality. It is not black or white. Does it work? Does it not work? It is far more nuanced. So if you've gone down those traditional routes and you have not found any improvement, like that's okay. Most of my patients have not either, and so I think finding a really good functional neurologist, a really good neuro-optometrist, I think those are the best areas that really have done a good job understanding the complexity of the brain-eye connection. And once again, because people hear vision and they just want to focus on the eye. And there's so much more to the eye than just what we can see in the anatomy, right? It's everything from the nerve back that gets disrupted with most concussions.
Yeah. So anyone watching us live, feel free to drop a question in the comments if you have any. And I heard somewhere that the average brain injury patient sees 8 to 12 different providers before finding like functional neurology or someone who can help them in any way. And like, no wonder it's so discouraging, right? Like you go to 8 different doctors and they all tell you there's nothing we can do. You start to believe it. And, you take them at their word. Okay, I guess no one can help me. And so I know when I finally found functional neurology, I was so skeptical at first. I was like, what are they going to do that, nobody else has been able to do for me? And then I was just blown away. Like in my initial exam, my exam was like 2 hours long, but like in the first few minutes of my exam, he used, what's that called? The optokinetic,
the stripes.
The stripes. And I was like, oh, stop. It makes me dizzy. And he was like, yep, it's your eyes. And I was like, oh my God, someone believes me. And so just like having the validation alone was so huge for me. And then, finding the different exercises and such that actually helped me. Just checking to see if there's any comments. Does anyone have any questions, comments? I see there's a handful of people watching. Go ahead, drop a comment. Yeah, anything else that you would like to add that we haven't maybe talked on?
No, I think those are, I think, like you said, the big pieces. I think, like you mentioned, with 8 to 12 doctors, it can be discouraging because we think, well, hey, this person is a doctor, and it's a big institution, right? I'm at Mayo, or I'm at Hopkins, or I'm, at, I don't know, whatever the big place is. And so it's like, well, if this person can't solve it, like, how can this other person here? And so it's going back to, it's like, sometimes it's just the wrong tool for the job. They're great at what they do, but I think this industry, the ones who are really on the forefront are, there's a lot of great physical therapists who are doing amazing work, neurooptometrists, and I think functional neurologists. I think those are the three professions who are really, in my opinion, the experts when it comes to them. And I think neuropsychologists are the ones pumping out a lot of the research, but I was just at a conference, and they are starting to now integrate a lot of the vision and understanding that that's a big piece. So there are practitioners, you just have to find the right disciplines. So I think functional neurologists, neurooptometrists, there's some great physical therapists, and there is a growing body of neuropsychologists that are starting to, I think, really look at the full picture as well. As like, those are the individuals that will really be educated in guiding you how to recover from a brain injury. Unfortunately, I think these other professions is they just are not given the resources.
Yeah, they just don't know what to do.
No.
And and I think there's this expectation, like, we all at some point get sent to the neurologist, and there's this expectation, like, well, the neurologist must know what to do because they got neuro in their name. But that's actually not what they do. They diagnose, conditions like Alzheimer, dementia, MS. They don't, most of them don't actually work with brain injury. And so, it gets so discouraging.
And they don't treat, when I say treat, I mean beyond medication, or if they are a surgeon, like, that is their treatment. I think that's the important thing, is like, they will not be partaking in the physical rehabilitation side. They'll refer you out to a physical therapist or another individual. So that's another big piece as well. And I would agree with you, and I don't know what's going on, but it is probably one of the biggest things I see is, like you said, is like neuro, it's in it. It should be one of the most well-versed. And I find other disciplines almost more well-versed, which, once again, I think it's the system. It is the system. It is the resources. It is how you look at it, the questions you ask. So it's not that there's a lack of capability. They're perfectly capable. It's just, it's a different thought process.
Not their wheelhouse. Exactly. Well, Dr. Perry, thank you so much for being here and sharing. I think another really important topic, something that affects, like I said, the vast majority of people with the TBI, I think, have some sort of visual component to it. So thank you so much for being here today and sharing with us. If someone would like to work with you, your website is integratedbraincenters.com. And I know that they can get a phone or in-person consultation with you. Tell us a little bit more about that and how that all works.
Definitely. So so we do free 30-minute consults with individuals locally, around the country, kind of all around the globe. And the point of those conversations is to kind of get to know the case and see if we can shed some light on some things that would be helpful, or if we think we would be a good fit. Or a lot of times it's finding a really good resource in your neck of the woods, right? So if you're in New York, or if you're in Florida, it's saying, hey, who else can we find around you? So I think they're really helpful. The goal is to help guide direction of like what should be done, right? Whether that's working with us or working with someone else. I think they're really helpful in guiding people, like, well, what should I do? Who should I see? But we do have individuals fly. We have a lot of local people in Colorado. We also have a lot of people out of state, that if people are wanting to come to travel to see us and work with us, we are more than happy. So we have individuals fly out, sometimes for a few days, sometimes for a few weeks, to work with us with the goal of trying to get the needle moving on their recovery and really creating a good game plan for them once they go home to continue to recover.
Awesome. Well, again, Dr. Perry, thank you for being here. And just thank you for all that you do for the community. We appreciate you.
Well, thank you, Amy.
All right, we'll see you all again next month for our monthly TBI Talks with Dr. Perry. And we will also have Dr. Shane Studman here next month as well. So we will see you all then.